Hello, welcome everyone to the second day of the Society for Prevention Research 2020 annual conference coming to you virtually. Hope you enjoyed yesterday's program, in which we started off with an interesting panel talking about understanding neighborhood effects through geography, architecture, and addiction science. And as a note, all these live presentations will be available on our SPR website in approximately a week. Today we'll continue with our conference theme, Why Context Matters, towards a place-based prevention science. Just want to give a couple highlights. The plenary session starting off will be called Place-Based Prevention, and following that will be an invited symposium entitled Addressing the Needs of Neighborhoods and Communities of Concentrated Disadvantage, a Research and Policy Agenda. In the afternoon, you can see the Early Career Preventionists Network, ESPN as they're called, and their symposium is called Using Existing Data for Research Strategies for Secondary Data Analysis. And then closing out today will be the SPR Diversity Network Committee Symposium called Place-Based Approaches for Health Equity Among Members of Marginalized Groups, Weighing Reach, Adoption, Effectiveness, and Scalability. So it sounds very interesting. With that, I am pleased to introduce to you Dr. Elizabeth Ginexi of NIH's Office of Behavioral and Social Sciences Research, who will chair today's plenary. And take it away, Liz.
Thank you so much, Michael. Welcome to Plenary Session 2, Place-Based Prevention. I'm Elizabeth Ginexi from the Office of Behavioral and Social Sciences Research at the National Institutes of Health, and I'm so pleased to be chairing this session today. The idea of place-based prevention is to explicitly consider how the locations of people, such as neighborhoods, the built environment, or activity spaces, is key to our full understanding of how best to intervene for prevention and community health promotion. Our plenary today will feature 3 engaging experts who will bring unique perspectives to this year's conference theme, Why Context Matters, towards a place-based prevention science. The talks in the session will progress in order of levels of analysis, starting with levers of intervention at the family level in the first talk, then to the community level in the second talk, and all the way out to a population city level in the final presentation. We'll begin today with Dr. Bridget Freishler, who is Professor and Associate Dean of Research at The Ohio State University College of Social Work. Her talk today is titled Parenting in Public, Parents, Activity Locations, and Physical Punishment. She will describe her research that examines how locations and context affect parenting behaviors and child maltreatment. Our second speaker will be Dr. Megan Sandel, Associate Professor of Pediatrics, Boston University's Schools of Medicine and Public Health. Her talk today is titled How Individual and Community Levels Interplay in Inequities. She will tell us about her research aimed at improving the health of vulnerable children through careful consideration of family hardships tied to unstable and unsafe housing conditions. Our final speaker, Dr. Charles Branas, is the Gelman Endowed Professor of Epidemiology and Chair of the Department of Epidemiology at Columbia University. His talk today is titled Changing Places for Health and Safety. He will describe his research incorporating place-based interventions and human geography, including some of the first citywide randomized controlled trials of urban blight remediation. Each speaker will have about 20 minutes to present, and after completion of the presentations, we should have about 20 minutes for Q&A. As you listen to the 3 talks, please type your questions and comments for the speakers into the chat box, and you may also react or concur with the comments from your fellow conference participants in the chat. The most popular questions will then rise to the top for our discussion at the end, and we really look forward to engaging with you. So without further ado, let's begin with our first presenter, Dr. Bridget Freishler. Thank you.
Thank you, Liz. As Liz mentioned, I'm going to be looking at microcontext where parenting occurs. to assess whether these contexts might be natural opportunities to intervene in problematic parenting. Now, this assumes that a lot of child maltreatment is situational, not pathological. Next slide, please. Traditional approaches to community-based prevention as they relate to child maltreatment are often place-based, and they focus on those residential neighborhoods when identifying and addressing the problem. While this can be good because it limits the intervention to specific geographic areas that are extremely high risk, particularly those areas that might be entrenched in problematic parenting practices over time, it may not adequately address overall rates of child maltreatment. Another concern is that these interventions use administrative child welfare data. Those are official reports of child abuse and neglect, which we know are biased as we have a disproportionate number of racial ethnic minorities in at all levels of the child welfare system. Next slide, please. So as an example of that, this is rates of referrals per 1,000 children in Sacramento over a 15-year time span. And you can see that there are a couple of areas that even though rates are decreasing over this time, that they have entrenched areas. Next. One of those areas is up in the north area of the city. And then next, in another area is in that more southern. So if you're thinking about place-based preventions, at least in the beginning of the early 2000s, these might be the places that you look to. Next, please. Now, this particular map is showing, is slicing those official data a little differently. It's looking at the substantiations per referrals. Substantiations are where someone has investigated and said, we think that this child abuse or neglect occurred. Those referrals are just those calls that go into the child welfare system asking you to investigate. Now, when you look at this, next, and next again, you can see that those two areas we had identified earlier look much different. It's much harder to tell which of those areas have higher rates of substantiations per 1,000 referrals. So if you use different ways of slicing these administrative data, you're going to find different neighborhoods where you might want to do some place-based prevention area. Now, this approach also assumes that neighborhoods are the primary and most important ecological context for those parents. But what if they aren't? Next, please. If you think about your regular day, well, your regular day pre-pandemic, you're likely to go to a range of places that represent where you spend time, including where you buy groceries, where you shop for clothes, bulk items, things you probably don't need, where your kids go to school, your doctor's office, where you get coffee, where we exercise. And when you think about those daily activities, do they all occur in the place that you live, your residential neighborhood? And if not, what does that mean for how we traditionally measure neighborhoods and the effect on social problems such as child abuse and neglect? Next, please. So now I'm going to take a little bit of a left turn to think a bit more about parenting within those everyday locations we used to spend time in and might spend time in again. What we know is that from observational studies on parenting, the context of where parenting occurs is important. So for example, parenting at a store will look different than parenting at the zoo or parenting at youth sports. However, in all of those locations, what is seen as good parenting is often shaped by public perception, and that the feedback we get, whether it be verbal or nonverbal, when we are outside of the home. And some of these micro interactions at these places from weak ties might affect how we parent in that moment. So if you have a young child or have had a young child, have you ever been in a public place where your child starts to throw a tantrum? What were the other people's reactions? Did you have some roll their eyes and say, my kids behave better than that? Did they give you knowing smiles because they've been there? And does that affect how you respond? One of the things that I've been observing through the pandemic is that parenting in public has been on display. Next, please. For example, this mother tried to circumvent any negative comments about parenting when grocery shopping with her 5-year-old daughter. The The sign says, I'm only 5, I can't stay home alone, so I have to buy groceries with mommy before you start judging me. Stay back 6 feet. These interactions, unfortunately, also remind us that issues of racial equity exist even within these mundane, everyday microcontexts. Next, please. Here's an example of a woman in a Kroger parking lot, a white woman who blocked a Black mother's car from leaving the store's parking lot. Inside the store, apparently one of the children of the Black mother stepped on a shelf to reach a drink, and that upset the other woman, the white woman. Now, I will say I'm 5'3", so I may have stepped on shelves at stores before, so I'm glad nobody was upset by that. But these examples show that how you parent in public may be shaped by the interactions you've had in those spaces, the comments you may have heard. But looking solely in residential neighborhoods, you may miss opportunities to prevent and intervene in these situations. Next, please. So in the larger neighborhood effects literature, people are moving away from residential neighborhoods in some respects and moving more towards activity spaces or activity locations. So activity spaces are environments where parents are spending their time, such as work, children's school, friends, family. And then that means that the activity space is going to be unique to each individual and reflect sort of their individual movements during the day. Examining activity spaces, or at least those activity locations, as opposed to residential neighborhoods, could vastly change how we characterize the risks a person exposed to and the resources available to him around a lot of areas, but in particular around parenting. So the purpose of this study, next please, is can we start to identify those microcontexts using activity locations? So among parents who report using physical punishment, where are they using the same activity locations or not? And then this is more for discussion. Our study didn't look at this directly, but if parents who use problematic parenting behaviors cluster in the same location, can we identify interventions for those microcontexts? Next, please. So what are activity locations? These are those locations where individuals conduct their daily living activities. We asked in a telephone or web-based survey for the information on the following locations, address information: home, grocery stores up to 2, the children's school or preschool, parents' employment, or if they were attending school, their school, and another retail store. Next, please. We're using data from wave 1 of a 2-wave study on parenting, activity spaces, and substance use. In this particular sample, we're only using the respondents who were in Sacramento City. We had 30 different cities. We're only using those for Sacramento. The parents were recruited via listed samples or Craigslist, and we used multimodal survey administration. People could respond to the survey either via the web or the telephone in the first wave. Next, please. Among these 90 parents, we had 273 activity locations. We identified the physical punishment clusters using StatScan. And for our purposes, physical punishment refers to endorsing an item of physical abuse that was on the study or one of the corporal punishment items on the study, and referred to using those parenting behaviors in the past year. We also ran a similar analysis to look at clusters using official child physical abuse data from the child welfare system to compare what these locations look like. The difference with the official reports is we only have addresses of where parents live. We don't have any information on where they spend time. So what did we find? Next slide, please. Among our 90 parents, we found 16 activity location clusters. So these are activity location clusters where parents who report using physical punishment both spent time. Over 80% of these were stores. It incorporated a third of our sample, and it occurred at 35 different activity points. These clusters, we should note, included parents who did use and did not use physical punishment. So we looked for clusters, and then after we identified the clusters, We could go and look to see were these only used by parents who report using physical punishment, or was it used by those who report physical punishment and also nonviolent discipline parenting techniques. In the child welfare system, we found 88 clusters using the official child welfare data. They covered 962 families, but because these were residential addresses only, we don't have the full range of information on where these parents might be spending time. Next slide, please. One interesting thing that we found and didn't expect is there was no overlap between the physical punishment activity clusters and the child welfare physical abuse data clusters. So the yellow on the map are the activity location punitive parenting clusters. Red is the substantiated physical abuse. The blue are those locations where we had someone identify that they spent time, but they weren't in a physical punishment cluster. And you can see two things, that they're spread out, particularly the parents who were in the punitive or the physical punishment clusters are spread out quite a bit over the city of Sacramento. But the clusters of substantiated physical abuse, they sort of, while they may not be next to each other, they were sort of in these similar areas. Next, please. So the thing that I think surprised my team the most is that these clusters were in stores. We expected to see residential neighborhoods, thinking that those are the places where people would cluster, given what we know using data from the child welfare system, because that's how we saw clusters there. But as we start to think about it, I have several members of my team who are parents who said that, you know, stores are charged parenting environments. You have a stressed parent, tired, overworked, hoping for a quick shopping trip, bringing your kid. And sometimes the expedient method of discipline is physical punishment. Now, to be clear, this particular study, we didn't study parenting behaviors in the stores themselves. So there's still much to untangle, and that's a limitation of the study. And I can tell you we're already planning observational studies in stores that got a little sidetracked over the past few months. But it does give us some ideas about how we might think about location, particularly among parents, and what that might mean for intervention in ways that we haven't really thought of before. Next slide, please. So if these activity locations continue to be important in this work that we do, what does that mean? Next. That means we have to think about changing the shopping experience. And this could be in a number of different ways. Next, please. Part of this could be the physical environment. Child-proof checkout lanes. If you're going in a checkout lane and it's got all kinds of candy, brightly colored little toys that kids might want, that can be one of those instances that could be emotionally charged for parents. Is there an area that could be dedicated to families taking a break from shopping? If a kid gets overwhelmed, is there some place you can go to sort of help them relax? Next, please. Are there positive distractions that could occur in a store? Coloring supplies, a treasure hunt. There are a lot of Trader Joe's restaurants that have a stuffed animal that they hide. And if a child finds it, they can go get a sticker or something from a Trader Joe's employee. So that's one way you can keep the child distracted potentially. And then the other thing is bystander and interventions. Next, please. These are interventions where people who could be watching see some problematic behavior. They could intervene in a way that is supportive of the parenting, but also could try to redirect either the behavior of the child or the parenting behaviors of the parent. Now, when we did this analysis and wrote this paper, we didn't have a global pandemic in mind. So we've thought about what this means a little bit more in the context that we're in right now. Next slide, please. So one of the things that we've noticed is the shopping experience has changed, and that when you think about these micro-contexts, you can't think about them without also thinking about racial equity. Next, please. So what if, and then I think you can hit one, yeah, there we go. What if you had if you have your child melting down, you hear this at the store. So 2 examples that I reviewed from Twitter: a toddler's melting down in the library, the mom is mortified. A stern old lady approaches and I hold my breath. It's okay, she tells the mom. I've been there, you're doing great. And then to the toddler, you're doing great too. You're doing your best. And then another, I will never forget the time a woman approached me at a grocery store when my kid was melting down after I told him no. I'm sure my face was red with shame. You did great, she said. You said no and you didn't back down even when he got upset. Good job. So what if that is the approach you have to parenting when you're parenting in public and your kids aren't behaving as you might like? Next, please. Instead of this reaction, next again, and one where you're being berated for doing this. Even as I suggest this, I need to note that the examples that came from Twitter, and when looking at those profiles, it appears to be a largely white upper class sample. Other examples that I didn't include are talking about supporting parents on a plane. And so that might limit who sort of was doing that. But how do we ensure that that same support for parents who are using these stores where there are more mix of populations, that they get that same supportive experience? As I said before, the shopping experience is already changing at a financial cost. Next, online ordering. Next, and then you can do the next after that. There's curbside pickup. There's grocery delivery. Those are things that we talk about in this paper even before the pandemic. And one of the things that we were worried about next, and I think you can do 2 more next after that, who then will not be able to avoid these charged shopping experiences, right? So shopping, we're looking for no contact. We're looking for something that's easy. Unfortunately, low income single parents, many who might be racial ethnic minorities, are the ones who aren't going to be able to avoid them. And so might feel shame, might feel that they need to use these expedient punishment measures to get the children to behave. So I certainly, along with my team, were intrigued by understanding these parenting in public as a way to understand situational characteristics that lead to physical abuse, but we're also cautious. As we move forward thinking about parenting in these micro contexts, we need to pay attention to how they may further perpetuate disadvantage or health inequities, particularly in our vulnerable populations. Thank you.
Thank you. That was wonderful. Our next speaker is Dr. Megan Sandel.
Great. Thank you, everyone. It's really nice to be with you today, and I'm really looking forward to talking about place-based prevention in a context of taking the really amazing talk that Bridget just did around connecting individual characteristics in parenting context. I'm going to take it kind of one level up and talk about how individual and community interact in how to think about it. Next slide. As we think about the talk, I'm going to give you kind of a roadmap for what I'm going to cover. I want to first talk a little bit about social factors and about how social factors in place can drive outcomes. And I'm going to kind of emphasize a couple of key points: positive and negative, interaction, and then multi-level. I then want to kind of dive deep into one particular hardship, which is unstable housing and its impact on caregiver and child health, and how it impacts other hardships, so that you're seeing kind of the multidimensionality in the individual space, and then be able to talk about how the individual and community levels start to interplay into building up inequities. And then lastly, I just want to emphasize why equity is such an important part of as we think about place-based prevention, since we know these place-based inequities are not accidental, they're intentional, and they need to be dealt with just as intentionally. And then it'll be really great to go to Charlie and his talk. Next slide. So as we think about social factors, I think it's really critical to make sure that we kind of focus on 3 things that I don't think always enter into as we're talking about kind of the social determinants of health. I think the first is, what I like to always emphasize is that my children have spectacular social factors that drive their health outcomes. They have 2 parents that are doctors. They live in a really wonderful school district. We live near a park. We live in a safe neighborhood. We're able to own our home. All those things are social factors that give them a leg up in terms of being able to be the most successful. And when you look at their success, you may attribute it to my parenting. You may attribute it to the individual factors, but we know that those are factors that are positive, that are, again, not evenly distributed. I think the other piece is that as we think about the interplay, social and negative factors can be interrelated. You may have a patient or a family that are living in a neighborhood that has violence, but it also may be where they have their church. It may be where they have a corner store that will let them buy food on credit if they run out of money at the end of the month. And so I think we tend to, in our effort to be the most scientific in understanding an individual factor, I think we tend to go towards negative factors, not always positive factors, and we tend not to do the interplay. I think the second factor is this idea that there isn't always, in a single individual family, they may have the same circumstances and may make different choices. So that as we think about something like food insecurity and housing insecurity, some families may prioritize making sure that they're not food insecure and then therefore fall behind on rent. Whereas another family may choose to actually make sure that they keep up to date in rent and become food insecure. And so it's hard always to understand those types of factors. I think the last is to understand the structuralness of all this, that again, people are necessarily experiencing hardships, not through necessarily their own choices, but actually through the structures that create them. I'll be showing you many maps that follow along the redlining maps of the 1930s, where there was systematic discrimination in who could or could not start to develop wealth as it related to real estate. And so as we think about that, I think it's always important for us to not just think on the individual or even on the neighborhood level, but to think on the structural level as we move forward. Next slide. I always like to describe kind of housing stability as an iceberg. And so if you could click the next slide, we describe a lot around homelessness, and homelessness as being a really important part of it. But what I like to say is homelessness is the part of the iceberg you can see. There's a lot of iceberg below the surface. Next slide. There's really a lot of people that are housing unstable. Next slide. And they're associated with things like multiple moves, which is defined as if you ask someone, how many places have you lived in the past year? And if they answer 3 or more, it implies they've moved twice. It also is about this concept of behind on rent, which, next slide, really the root cause of which is unaffordable housing, your inability to juggle all of your bills. Next slide. I'm part of a research policy network called Children's Health Watch. Children's Health Watch is based out of Boston Medical Center, but we actually collect data in 5 cities across the country: Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. We've been around for over 20 years. And the research network was founded by a group of pediatricians really concerned about how policies were playing out on their patients who they were treating already for failure to thrive. And so in the late 1990s, with welfare reform, they wanted to collect through a Sentinel research project interviews with families with young children 0 to 4 years of age, because this is the critical window when you're growing kind of the body and brain that you need for the rest of your life. And you are particularly susceptible, almost can think of it as the canary in the coal mine of these policy changes. And so they started collecting data in the late 1990s. This particular sample that I'm reviewing today, we published in Pediatrics in 2018, looking at 3 forms of housing instability over a 5-year period with low-income renters, renters who had a public form of insurance, so had met a certain income criteria. We interviewed over 22,000 families in those 5 cities with a child 0 to 4. And what we were really shocked with was kind of 3 things. I think the first is that over a third of the families that we interviewed had a form of housing instability, 34%. Most of that was in families reporting being behind on rent, a little over 27%. 8% reported multiple moves, and 12% of our sample reported at some point in the child's life, either prenatally, postnatally that the families had experienced homelessness. Each of these factors was associated with adverse health that I'll show a little bit later, but they were each independently associated. I will note we have previously published in the American Journal of Public Health. Diana Cutts, one of our lead investigators, was the first author on overcrowding and its association with adverse health. In this particular sample, though, we did not find overcrowding was associated with adverse health after multivariate regression analysis. And so we just focused on these three forms. Next slide. The other thing that kind of shocked us was that there wasn't a lot of overlap between the groups. As we looked at the group that was behind on rent and the group that was multiple moves and the group that was homeless, what we found was that if you were positive for one form of housing instability, 86% of the time you were only positive for one. And so it kind of underlined that these are distinct groups. This isn't necessarily a continuum or interrelation. These may be distinct factors. Again, certain families may opt to move multiple times and not enter a homeless shelter, or may be able to avoid a homelessness or having to move and hold on to their home despite falling behind on rent. Next slide. The last thing that I just wanted to emphasize is as we stacked up the adjusted odds ratios, which in this bar graph you can see the stable housing is the red bar, the behind on rent is the purple bar, the green is multiple moves, and the blue bar to the left-hand side, or the right-hand side, sorry, is the homelessness group. What you'll see here is we've always known that homelessness is bad for your adverse health. But what you can see is when we stack up the adjusted odds ratios in the child fair poor health, the maternal fair poor health, the maternal depressive symptoms, the rates of food insecurity or healthcare cost trade-offs, is what you'll see is that yes, homelessness is bad, but that behind on rent group, that purple bar, is just as adverse. And so as we think about it, I think that we tend to think about homelessness or different types of hardships as extremes, when what our research suggested was actually that the behind on rent group had just as adverse health. And so if we're going to improve people's health outcomes through housing, we have to make sure that people don't fall behind on rent either. Next slide. So as we think about this, we can't talk about housing without talking about its context. Where is the house located? And I think that in many ways, COVID-19 just underlies the deep-rooted inequities that we see on the neighborhood level. This is a map of the city of Boston, and what you can see is the light blue on the left-hand side of the slide. That is marking the percentage of people in the city of Boston who are paying more than 30% of their income on rent. And you can see the central city has there's some on the kind of Alston, Brighton neighborhoods, and some of the South End neighborhoods are a little bit darker. The middle one, the gray, is actually the unemployment rate, and this is pre-COVID in terms of seeing that there's a higher rate of unemployment in the central city, which is a predominantly Black and brown neighborhood, the Roxbury, Dorchester, and Mattapan neighborhoods in Boston. And then what you see on the far right side in the orange is the infection rate. The higher, the denser of the orange color is the higher of the COVID-19 rate per thousand. And so as you're seeing, those same neighborhoods are lighting up in terms of both economic outcomes and in terms of infectious outcomes related. Next slide. Another way to necessarily reflect maps is through opportunity mapping. This is an opportunity map that was developed by the Diversity Data Kids Network out of Brandeis, Dolores Acevedo Garcia and her team. And this is publicly available. You can pull it up, Diversity Data Kids, and be able to pull up census tract opportunity mapping. The opportunity mapping formula is developed by the Kirwan Institute, and it takes 17 different factors and creates a 5-scale system of very high opportunity, that's the dark red, to high opportunity, moderate opportunity, low opportunity, and very low opportunity, which is that very light yellow color. One thing that a colleague of mine at Boston Medical Center, Dr. Renee Boynton-Jarrett, as part of her Vital Village network, is that she pulled out of our electronic health record the blood pressure readings of 3-year-olds. And what she looked at was what was the prevalence of those blood pressures being above the 95th percentile at age 3. And so what you'll see represented on the opportunity mapping, and again, those central city low opportunity neighborhoods is the larger the circles, meaning the higher the prevalence of blood pressure readings. And Renee and I published this in Academic Pediatrics in 2016, arguing that if you're going to be talking about ending child poverty and what the health outcomes are, we had to talk about neighborhood level interventions, not just individual level interventions, because of the lack of opportunity in many neighborhoods with high concentrations of low-income children. Next slide. I'm going to share with you now an approach called the medical legal partnership approach, which tries to think about ways in which legal structures create different levels of outcomes. And for those that are unfamiliar, medical legal partnership is an approach that first started in Boston Medical Center around 20 years ago. There now is a National Center of Medical Legal Partnership at George Washington University at the Milken Institute. And what you see is that you're seeing where you identify legal needs and are able to treat patients on the individual level, but you eventually move upstream to thinking about transforming clinical practice and ultimately improving population health through actual levels of intervention on the community and on the structural policy level. Next slide. I'm going to give this example from my friends and colleagues at Cincinnati Children's. I want to thank them for sharing their slides with me to share today. And what you'll see here is actually a letter that was delivered to a patient in their primary care clinic at Cincinnati Children's. And for those that, if you can read it, it says, "Notice to all residents. At this time, all residents are prohibited from installing air conditioning units in their apartments. Anyone with an air conditioning unit will be evicted immediately." Now, one of the things that's interesting is that this clinic had a medical legal partnership on site. And so the pediatrician had been trained. They said, this doesn't seem right. It doesn't seem like you should be evicted for having an air conditioning unit. In fact, this child had asthma and they were concerned about the heat and whether or not that would be a problem. And so they sent the patient down to the office down the hall to where the lawyer was sitting. What was interesting is that the next day, another patient showed up with this same letter that was given to them. And so the same pattern happened where the pediatrician sent it down and the lawyer started saying, this is strange. Why are we seeing these letters? Next slide. And so what they ended up doing is they ended up mapping the cases of asthma related to both these letters and also to other housing code violations. And they started to see a pattern where the medical legal partnership at Cincinnati Children's is called Child Help or Health Law Project. And what you can see is the dark little houses are where they've seen child help cases. And the white houses are where they are actually seeing a pattern of buildings owned by a firm. And what they were able to uncover by mapping individual cases was actually that this firm had systematically stopped investing in fixing the repairs of their buildings and had threatened evictions around air conditioning units. So the next slide was, the solution was, next slide, and the next slide after that, what they were able to do, and this was published in Pediatrics, was they were able to show that through the medical legal partnership approach, they were able to discern this pattern, and they were able to actually show that they were forcing the sale to a new firm, the Community Builders, that was able to actually start repairing. You see they're actually repairing the roof proactively. Next slide. What was interesting is that they then didn't stop there in Cincinnati. They actually looked at different patterns, next slide, of asthma. And so they showed that there were neighborhoods at the far left that had much higher rates of asthma hospitalizations than the lower quintile. And so the next slide, they actually lifted out one of those neighborhoods, the Avondale neighborhood. Next slide. And what you can see is they actually mapped the number of housing code violations in that neighborhood. What was interesting is you can see this heat map. There were certain areas that were much lower. Also on this map, you can note that there were a lot of schools, so there were a lot of children, but there were not a lot of pharmacies. The lower end of the map shows where the pharmacies are. Next slide. And then what they did is they tracked children who had come to their emergency department. And what they showed was that they associated the heat map, the likelihood of having a new ER visit related to asthma after having a first ER visit, related to their community level. And so what you can see with Cincinnati is they started with an individual level, they created a community level pattern and made a policy solution. And then what they did, interestingly enough, is they took a community level pattern and brought it down to an individual level intervention. They actually published just this past fall where they actually cooled the hotspot in that neighborhood and were able to reduce the number of bed days in that neighborhood by 18%, different than a subsequent other neighborhood where they did not do the intervention. Next slide. So one thing that I just want to emphasize is that as we think about these factors, it's not to stop doing individual level research. That's where we do a lot of our emphasis in prevention. But I urge us to move upstream to thinking about ways in which we can also tell data stories related to policies and structures, ways in which by intervening on the policy and structure level, we can see individual level improvement and population health improvement as well. Next slide. In my last slide, I just wanted to emphasize equity. And the reason for that is that as you think about it, oftentimes we think about prevention as treating people equally and giving people the same equal treatment in order to prevent an outcome. But what you'll see on this slide is that on the equality side on the left-hand side is if you have three-heighted people starting from different places, and you treat them equally, you each give them one box to stand on, you don't actually achieve the same equal outcome. Only the tall person gets to that apple of opportunity of the tree. It's only when you treat them equitably, you change your approach based on, say, where they live and where they are, and you're able to show that you can actually get to that same equal opportunity. We have to acknowledge that people are not different heights by accident. Structural racism and oppression are reasons why we have the inequities that we're seeing today. And so what I really encourage is that as we're thinking about research moving forward, what are the ways in which we can infuse equity into place-based prevention to understand the inequities of place and to address them systematically through rigorous research to show that we can get people to be able to have the same outcomes while still acknowledging that they aren't starting from the same places. Thank you very much.
Thanks so much, Megan. That was terrific. And now for our final speaker, please welcome Dr. Charles Branas.
Hi, everyone. I'm very pleased to be here. I'm very pleased to follow two wonderful talks. And I'm going to touch on aspects of both those talks. I was very excited to see some of the discussion already. So I'll talk about broadly about changing places for health and safety. Can I get the next slide? But I wanted to start by giving you a little bit more of where we've been as cities in the United States. And I pulled this from a great article in The Atlantic a few years ago by Ta-Nehisi Coates, talking about, the title of the article was The Case for Reparations. And in it, there are maps, redlining maps. This one in particular is of Chicago from 1939. And what he then does is then compares these to vacancy and the occurrence of vacant houses in Chicago. And you can see the map to the left from 39 and then the map from 1950 in Chicago for vacancy and where it was only 11 years later. And the maps look somewhat different. Next, please. But when you move it forward to 2010, what you do see is that the redlining map of 1939 and the racist policies that generated that, that were supported by the city of Chicago and supported by the federal government on into state government and so forth. So these were formalized structural policies of racism that led to the abandonment and the vacant housing, and those maps cross over very, very closely. Next slide. And this spiral has occurred in many cities around the nation, whether it be Chicago, Detroit, Cleveland, Cincinnati, Philadelphia, Houston, you name it. The spiral of these racist policies, the subsequent disinvestment in these neighborhoods, and disinvestment over the long term, we're talking 70 years plus of disinvestment targeted at specific neighborhoods, which has then led to abandonment that you see here of both buildings and land in these spaces. And I want to talk about the two of those as related but distinct coming up. Can you, next slide? So the way that we're thinking about this working is that this spiral of structural racist policies, disinvestment, and abandonment, if you think about abandoned and vacant places in our cities, next, these are visually unpleasant. They are chronic stressors. I'll show you some research on that in a second. The people who live near them are, it affects their lives every day when they step out of the door to go to work or school. And it's not the good kind of stress. It's not temporary. It is a persistent and unpleasant stressor. Next. This disconnects the residents. It creates anonymity among residents. They are both unable to connect with their outside spaces, and they are unable to connect with each other as well. And this creates a lot of fear, both between people, but also of the spaces themselves. And again, understand that this is an experience that people have every day when they step out their doors. Next. The disconnection and the fear then, not surprisingly, leads to a reduction in quality of life, leads to a reduction in civility. Next. And what happens is residents who are able to, yes, who have the means and the resources to leave these neighborhoods. And also, very importantly, businesses close in these neighborhoods. And not just mom and pop businesses, which are key to the vibrancy of the neighborhood, but anchor businesses, things like supermarkets and banks, close in these neighborhoods, leaving the residents that remain with few opportunities for the most vital things in terms of their economics and their food in these neighborhoods. And then next, and of course, this then leads to more abandonment in places, and the spiral just continues. So we thought many years ago, we began asking questions about, well, what can you do about it? Next. And just as epidemiologists want to interrupt other negative patterns, we thought, why not focus on the abandoned places? Now, you can focus on anything in this spiral, but we thought about the places themselves as potential opportunities to try to break the cycle. Next. Now, for those of you who don't know, this is a map of Switzerland. Next. If you add up all those places and spaces, those abandoned and vacant places and spaces in cities across the US, and I'm talking not just about our 30 or so major cities over 1 million, I'm talking about mid-sized and small cities as well. If you add them up, the land area of those vacant and abandoned places adds up to an area the size of Switzerland. This next. So this is a big challenge for the United States. And this is something that has been growing and festering for decades. Next. It is a major challenge, but we also see it as very much as an opportunity. Next. And a number of groups around the nation have been thinking about what I like to call in situ place-based changes. That is changes to people's neighborhoods where they live, in-place changes, right? And these are designed not as luxury amenities to these neighborhoods or opportunities to have others who don't live in the neighborhood come to the neighborhood to use it in some way. I'm not talking to you about installation of a High Line in New York City. I am talking to you about what one reporter called the park of 1,000 pieces. Little parks and parklets in cities and neighborhoods that can be spread throughout the neighborhood that are three things, that are make structural changes to the neighborhood, whether it be dealing with abandoned houses or vacant lots or community gardens or business improvement districts, structural changes to these spaces that are inexpensive, and that can be readily reproduced, that make them both scalable and sustainable over the long term. So again, in situ place-based changes that are structural, scalable, and sustainable. Next slide. So our work began with a few early studies, but really began with community input, where we went to neighbors, and frankly, we were doing, and this is to Megan's prior point, we were doing a lot of individual-based work. And we're having some successes, but the successes and improving people's health on an individual level were very small. Maybe a couple dozen people at best were being affected. And we kept on talking to neighbors, and many of them had no idea about this. And we asked neighbors in a variety of communities what they thought we should do. And the question that we particularly posed to them was, what should we do about violence, and particularly gun violence that's escalating in your neighborhoods? Next. And we got comments like this, that you got to watch yourself walking past vacant lots because you don't know who's out there. Next. It's not safe walking past abandoned homes because the one across from me looks like it's getting ready to cave in. So people were clearly telling us, and by the way, telling us over and over again. They, of course, had many different recommendations about what to do, but the recommendations about the places and spaces that they saw every day were the things that seemed to rise to the top. Next. And finally, we got a lot of recommendations like this. If I could change things, I would. There wouldn't be so many vacant lots and abandoned houses. Next. And we began by doing a very small study of, in this case, 3 vacant lots, where the vacant lots, which you see here as the green rectangles, the vacant lots were treated, cleaned and greened and made into little parklets. All the other gray rectangles in the area are all the other vacant lots that were not treated in this particular space. And what we noticed is the dotted line is where people were walked in this particular study. So we put heart rate monitors on people and walked them. And next. And what we found that there was a significant drop in people's heart rate when they were in view of the newly greened lots. So this particular change was able to have a biologic response. So this goes back to the stressor that people feel over and over again in these neighborhoods when they step out of their doors. And this is work that was originally done by Gina South at the University of Pennsylvania. Next. And we went on to do quasi-experimental research where we looked at, this is observational research, where we looked at tens of thousands of vacant lots and abandoned buildings, converted from what you see on the left, next, to what you see on the right, this cleaning and greening process, next. And in these observational studies, we found as much as a 39% reduction in gun violence and stress as 2 particular markers we were looking at, that was sustained for something like 3 to 4 years, the extent of the study. And we also found that these are very expensive. As I said, we chose them to be inexpensive treatments to spaces, and that they return, for every dollar invested, there are potentially hundreds of dollars in return in terms of improved health to people in the surrounding areas. Next. So we then began to think about, well, you know, what about randomized controlled trials? People were still questioning whether this was really something that should be done in cities. Do we really have the highest level of evidence? Policymakers were asking this. And we thought, well, you know, obviously we can do randomized trials on things like aspirin and placebo, so why not next? Why not look at random assignment of places, of changing places in terms of different outcomes that we were interested in, whether it be violence, stress, or mental health outcomes in others. Next. So then we began to establish standardized treatment protocols. This is working with the Pennsylvania Horticultural Society, this particular study in the city of Philadelphia, where you can see the before, during, and after of treatment of vacant lots into green spaces. Many of these were immensely overgrown. The vegetation was incredibly high. And the process, which was done almost always by minority-owned businesses and landscapers in the surrounding area, many of whom were from the neighborhoods within which they were working. These were quick processes that could change the spaces over the course of a week or so. And neighbors were often pleased and quite surprised that this could be done. In many cases, people would tell us or the contractors that they've been calling the city for decades in the hopes that these places, these abandoned spaces would be changed. So standardized treatment protocols next, which then led us to, this is a first citywide randomized control trial in the city of Philadelphia, where we had about, of 30,000 vacant lots, we randomly selected about 600 and then randomly assigned them to different protocols, a full cleaning, greening, and maintenance protocol, a cleaning and maintenance protocol, and then a control protocol all the different arms, all 3 arms of the study, which we randomly assigned into, all received the full cleaning, greening, and maintenance at the end of the study. Next. And what we found among a variety of different outcomes, which I'm going to show you just a few of these here. Next, is that these are police-reported outcomes. Remember, we were very interested in gun violence, and what we did find is that gun violence and shootings went down by a significant amount, especially in the most in neighborhoods below the poverty line, as did nuisances and reports of nuisances, things like noise violations, disorderly conduct, and so forth. Those also went down by a significant amount. Next. So we thought of this as a form of win-win science. That is, we're showing that nuisances and gun violence went down. Next. But we also measured a number of things through a random sample survey of households in the areas that that were part of the study, in the neighborhoods. And we found that people also went outside more and relaxed outside more by a significant amount. And we found that in correspondence with the police-reported reductions in gun violence and nuisances, people also felt like, randomly selected neighbors felt like there was less crime in the neighborhood and less vandalism in their neighborhood. And very importantly, a number of different mental health measures were improved, including self-reported depression. So we think of this as an opportunity for win-win science. So there are significant results and a variety of co-benefits that came along with this sort of treatment of vacant and abandoned spaces. Next. So we have other randomized controlled trials that are currently active. We have an abandoned buildings work in Philadelphia that is treating a variety, hundreds of abandoned buildings in the city. And then we also have work on both buildings and land, greening of land and treatment of abandoned buildings in the city of New Orleans that's ongoing right now. Next. And just to sum up, these place-based experiments, whether they be greening, building trees, lighting, and so forth, across a variety of cities, and you see a series of references there, have shown anywhere from 6% to 56% reduction in really important health outcomes like gun violence, stress, and depression. And I have to do a shout out to Dr. Kuo and Bill Sullivan in Chicago, who did some of the very first work here in Chicago affordable housing, looking at tree canopy and not. Next. So take-home points that I'll put in here are, first, if you get the next one, programs that focus. This is taken from, by the way, from 1999, and this is a quote by Len Sine, who's a social epidemiologist at the University of California, Berkeley. And I think we all need to take this in place, take this in here as part of a place-based conference, is that programs that focus on places or structural dimensions can influence the lives of more people. So more people can be touched by them and for longer periods of time, that is their sustainability, than individually based interventions. Next. I think this is a point I make to many healthcare systems, and it is that you really can't expect your individual level treatments to work if the places that you are sending the people who you are treating back into remain chaotic and unhealthy. So treating the basic structures of those places should be a first step and should be always be an adjunct to individual treatments. Next. And then finally, I have to say that changing places themselves are important standalone treatments, and we might just approach these first, and that they do not need to be complex and expensive to have an impact, a positive impact on people's health. Last slide. And so I'll end where we started, and that is with the community voice and folks who were saying to us over and over again, and it took us a few years to recognize it, that if they could change things, they would, and there wouldn't be so many vacant and abandoned places. And John McDonald and Bob Stokes and I wrote about this and a number of different place-based change interventions in our book that's only recently out, called Changing Places. And I'd encourage you all, if you want to read more about a number of these different opportunities for place-based change, to look at our book from this past year. Thank you very much.
Terrific. Well, I'd like to welcome back all of the speakers. We do have a number of terrific questions in the chat. So let me see. I think everyone should be able to see these questions. Maybe we can start all the way back to the first talk. We had a question for Bridget. Do you know of interventions as to how to communicate to parents and bystanders appropriate way to respond to difficult shopping situations?
Yeah, so these bystander interventions for to prevent child maltreatment are fairly new, but there are a couple that are showing good effects. And their advice is don't give a harsh look, don't give a side eye, try offering kind words to the child or distracting the mom with a question, maybe about a particular cereal. They're in a cereal aisle to help them move to a different frame of mind. So really just being positive and distracting are some of the techniques that they are providing in their training for this.
Moving more toward the neighborhood and place interventions, we had a question from Dorothy who said, I'm reminded of some of the unintentional consequences of intervening in neighborhoods or places. How are you including the voices of the neighborhood in determining place-based interventions? Sounds like maybe Megan or Charlie.
Yeah, I'll go first, and then I'm sure Charlie will have others. I sort of rushed a little bit at the end. So for those that want to learn more about what Cincinnati Children's did, that Cooling Hotspots article is from the fall of 2019. Andrew Beck is the first author, B-E-C-K. And what the interesting thing that they did in that I think is really important is that they used quality improvement principles where they had a design team that thought through what are the things that we're going to try and do in this neighborhood, and they include neighborhood members on their design team. They have these like resident researchers. So they were viewing people who lived in the neighborhood as colleagues and equal voices in how to design the interventions. And what was interesting is that they did adapt, just like what Charlie referenced, and I think Bridget also talked about, taking context into account in terms of how you design an individual intervention. So for them, if you had a child who was for asthma and was getting discharged to that particular neighborhood that they knew didn't have a lot of pharmacies, they would actually institute a med in hand. They would make sure the child didn't leave the hospital without all of their medication. And if they knew it was in a hotspot that had a lot of housing code violations, they would automatically send someone to knock on the door to make sure that everything was okay. And both of those were things that were vetted through their neighborhood kind of resident researchers to make sure that they were avoiding some of the unintended consequences you're talking about.
So I think that's great. And what we've done more of is bringing, just as Megan was saying, bringing community members onto our research teams to begin to inform what's going on, but then also marrying that and having those community members who are oftentimes some of the most motivated individuals in their neighborhoods. But we want to find folks who also don't often speak out about this kind of stuff, who may not have a voice. So we did go to lengths as well to try to get people involved who and get voice from neighbors who otherwise would not have said something about this, but who are still affected by it very clearly. And we always used our partners from the community who are on our research teams. Basically, they were our scientific partners on our research teams to help us make those bridges and to get the best input we could from community members. And by the way, that sort of work happens both at the beginning of when the questions are being asked, as I was showing, but also then that kind of work should happen, and we do, at the end as well. So after your numbers are taken into the stratosphere, epidemiologically, and you analyze them with the absolute best regression models and so forth, and all this sorts of thing, and publish them in peer-reviewed journals, or even before they're published, you should be taking the results back to the members of the community to get them to give you, to bring this back down to earth and have them tell you, well, that doesn't really make sense, or right, that corresponds with what we were thinking and what we had experienced. So this is a process that occurs throughout the science of these sorts of place-based interventions.
I really like that. So here's a new one. Dr. Branas, I'm a big fan of green spaces, but some research has suggested that green spaces are also a space for drug use and activity, especially amongst teens and young adults. Has your team assessed these factors in your research? And if so, what have you found? If not, how might you address such issues in the future?
Sure. We have looked into this, and to be fair, some of our work was funded by the National Institute of Drug Abuse to look at drug use outcomes. And we have yet to find anything, to be honest with you. We have one study that did show a reduction in illegal drug use, at least police reported. But those police metrics are not always so great. We have done a lot of, so we always work with anthropologists. So we're not just these quantitative epidemiologists and economists. We always bring anthropologists in who have done some participant observer work in the neighborhoods in a number of the cities. And what they're finding is that the newly green spaces, for instance, or the newly treated buildings seem to be opportunities where perhaps neighbors have been waiting for decades for this space to be treated or in some way improved, and perhaps have been calling the city and so forth. And once it gets improved, neighbors do not want it to go back to the way it was. So they will go out of their way to try to move things that are nuisances off of the spaces. And one of the things that we note that they will frequently do is move any kind of illegal drug activity off of those spaces. So we do have documentation of that. I don't know about for teens and young adults necessarily, but we do have documentation of that. And I will also say that folks who are who are part of an illegal drug market in those neighborhoods are very respectful of these spaces and of neighbors asking them not to do that here. And so I think there's been, although we haven't captured it numerically per se in a lot of different cities, I think there has been some positive benefit around drug use and activity.
It almost sounds as if the previously neglected spaces, now that they're protected, perhaps.
And we have an article coming out soon. John McDonald is leading that on the sustainability of this, and it seems like the vast majority of these spaces stay that way for perhaps as long as a decade that we can measure.
There's some related questions to this idea of improvements in neighborhoods, and one question asks about as you make changes, they may become more desirable, and folks might be concerned about gentrification or uprooting the existing residents. And have you thought of strategies about offsetting that?
Yeah, that is a very, very important question, and we have, and I think some cities have done things like trying to protect where these sorts of spaces are being created, trying to protect particularly multi-generational residents through things like reductions in property taxes and other things, and property tax control, rent control, and other things that have been successful. And I do think of things that have come out of, for instance, out of city council in Philadelphia that have had some successes. At least for the vacant lot greening, we've looked in the city of Philadelphia, and the origins of this kind of work was that a developer would be driving around and would pick up one of these spaces and develop it into a new home. That has happened, but only in a select, very few number of neighborhoods and a high number, and we reported in one of the studies, it's something along the lines of 95% of these remain in the original little parklet form that they were created a decade later. So if you drive around Philadelphia, you will see these all over the place, and that goes the same for other cities, whether it be Flint or Youngstown, Ohio is another city that we worked in, and they seem to remain that way for quite some time. Remember, the treatment here was selected not as a luxury development. It was purposely chosen. We are not creating the high line. So I think in answer to the question, which is super important, the question about gentrification, and is something that we need to be vigilant about, we don't think that has happened by and large up to now.
Yeah, I just want to jump in. I do think that it's exactly right. Gentrification is the thing that you don't want to have happen. That being said, I always sometimes want to pick apart the word gentrification. So gentrification implies both investment and displacement. And I think you do want the investment side of that. You just want to prevent the displacement side. And so I always want to really emphasize that what you're talking about is actually anti-displacement strategies, not anti-gentrification strategies. And there are some, particularly zoning and other types of things that cities are starting to do. Boston just passed an equity zoning requirement for the Boston Planning and Development Authority. And I think this is where, for those that are working with urban planners, I think this is where epidemiology and urban planning have not spent enough time together. And I think we could do really effective multi-generational impacts if we were able to marry anti-displacement strategies with, say, greening and other types of economic developments in these systematically disinvested neighborhoods that are predominantly Black and brown.
And there's to your point, there's a blossoming literature, a public health literature on gentrification and health. And I think we've only scratched the surface. So, we all need to start to invest in that and a better understanding of the implications here of that and unwanted displacement of particular multi-generational individuals and families.
I see one question from an audience member, I think that cycles back to the point in your slide, Charlie, where you had the diagram and you were talking about the stress that's created from closures of businesses. And the question had to do with when you look at those closures of businesses, do you look at food insecurity or the inability to obtain healthy food as one of the factors that might exacerbate stress and insecurity?
Yeah, so I have to plead that we did not look at that. I see that as an important thing, and I know others have looked at that, food insecurity, food opportunities, and so forth in the surrounding area, and I think it would be something that would be ripe for future study. Particularly, there is a literature talking about major supermarkets and those as anchor businesses that when they get removed in particular, things move to bodegas and other places then it becomes quite challenging to deal with the volume and to move different types of food opportunities to folks in the neighborhoods. But I think it's an opportunity for study.
Yeah, I'll just jump in. There is an interesting literature now around investment. So I think as we think about return on investment, oftentimes we want to be measuring that very, unidimensionally around things. And now more and more there are multidimensional societal return on investment metrics, because the grocery store business is like super razor thin. Like it's really hard to make money in the grocery store business. But for instance, in the Midtown neighborhood in Cleveland, a family-owned chain of grocery stores actually invested in putting a grocery store in the Midtown neighborhood specifically to revitalize that neighborhood, even though they expected to kind of lose money over the 20 or 30 year period. But many of the hospitals around that, particularly Cleveland Clinic and Case Western, both the university and the Children's Hospital, they helped invest in that by putting a clinic next door to the grocery store. And so I do think, as we think about it, what are the methodologies that allow us to analyze those multidimensional types of interventions to understand them, and what's the economic model that makes them sustainable? Because I'm not sure everything's going to have a $1 to $300 return that Charlie's able to show with the greening.
Yeah.
But I think we do need to have those economic models, because otherwise we're not going to invest in these multi-dimensional, multi-layer type of interventions.
Right. In terms of investment, there's a question that's somewhat related here about, and I think it pertains to follow-up perhaps in the intervened properties, Charlie, after they're greened and fixed up. What happens to them? You know, do you track that over time? Do the neighborhood, are they given opportunities to purchase them or rent them, or who owns these and maintains them, and what happens over time?
So in a lot of cities, it's a huge challenge. So in a lot of cities, these get put up in there are adopt a lot programs, adopt a building programs. There are sheriff sales of different buildings that have been improved to the point where someone may want them. Particularly local residents may want them, and it does happen. Land banks are another great idea. I will say that at least in the cities we worked in, there hasn't been as much, I guess, adoption by local residents as we would have wanted. And that's something that, as I said, they remain the way they were treated in the first place. And the fortunate fact is that the maintenance of these is also really, really inexpensive. So you can maintain them in the same condition, roughly speaking, year to year. But it would be nice if they were formally possessed and owned by folks in the neighborhood. Now, I will say there is a lot of informal, and we have documentation of this, of folks taking over, especially the little parklets and the little green spaces, and making them their own. There's all kinds of activities that go on, all sorts of sports, barbecues. I think there's been a few marriages on some of these spaces, and many different things where folks perhaps don't own them per se, but still use them, and they remain. The intent that they were originally put in there too was they remain public resources for that local neighborhood. But we would like to see more formalization of acquisition of these spaces, although it hasn't been as rapid as I think many of the creators of the program first imagined.
There's one question that might allow us to rope Bridget back in as well, and it has to do with whether you all have thoughts about place-based and individual interventions running concurrently, and can something like that be done successfully or sustainably? And certainly, Megan, you do individual and place-based. So anyone who wants to chime in on that, thoughts of running concurrent levels of interventions.
Megan, why don't you go ahead and start? I can follow up from you.
Awesome. Yeah, I do think that more and more you may see in some ways like 2x2 designs that may have both neighborhood level and individual level components. As we think about this concept, I'm a pediatrician, so I tend to think things in pediatric healthcare contexts, is whether or not if you treated someone with, say, a neighborhood vital sign, you had someone come in, I'll use asthma as the case example. Let's say you had them come in and you knew that they were from a certain neighborhood, and you randomized them to a different individual level intervention to try and see how things would be additive if you added in a neighborhood level intervention with an individual level intervention. Vice versa could be that you had two individual patients from different neighborhoods. They both got the individual level intervention. Only one got the neighborhood level intervention. I do think this idea of context being changeable, and I think Bridget's research is really important to this, is this idea of how you judge that complaint, whether it came from the store or not, in terms of a stressful situation, maybe an interesting type of new way in which we can design policies or other research.
So following up on that, in the field of child welfare and child abuse and neglect, The interventions have almost exclusively been individual or family-based. There hasn't been a ton looking at the place-based effects and how we might mitigate some of those stressors. A lot of research looking at, say, neighborhood effects, but not a lot of interventions. And one of the things we're starting to look at as a field is to see, are there ways that we can better understand where parents are spending time so that we can make sure they're getting access to resources, referring them to services in a way that might be in places they go. We're paying attention to where we might place children. Are we placing them in their same neighborhood where it might be easier for families to see them? Or are we placing them in another county where a family might not be able to see them? So when we think about context and how place-based might look there, it looks a little bit different. And I think it's been a struggle in the field of child welfare and something that is starting to see a little bit more information and investment from, say, the Children's Bureau to look at community collaborations and community context to be able to understand how you might be able to intervene on both these levels.
Terrific. I think that also implies some pretty complex analytic designs as well, and data collection strategies, but lots of opportunity here for innovation, for sure. I think we have run through the bulk of the questions here. Let me just check. A couple people asked about gentrification, so we pretty much covered that, I think.
Thanks for all the great questions.
Yes, it was really a wonderful session. And if anyone else who's listening has one final question and can type quickly into the chat, we can take one more. And if there's no more questions, I think we can adjourn. I want to thank all of our speakers, Charlie, Megan, and Bridget. This was terrific, and I appreciate the attention of everyone in the audience and the thoughtful questions. Please enjoy the rest of the conference this afternoon.